Picture this. 2 in the morning, rural ED. A 70-year-old rolls in with pneumonia, oxygen saturation's 88% on room air. You slap on a nasal cannula, titrate to 94% and move on to the next patient. An hour later, the nurse tells you he's desaturating again. His oxygen has drifted down because nobody had time to check.
Every single one of us who has worked a busy ward or ED knows this exact scenario. Oxygen is the most commonly prescribed drug in hospitals, and we manage it like it's an afterthought. We set a flow rate and hope.
Good morning. It's Wednesday, the 6th of August. 3 stories today: autonomous oxygen titration in hospital, antenatal corticosteroids in women with diabetes, and a drug for knee osteoarthritis that just failed its biggest trial yet.
Let's start with the oxygen story, because it published 3 days ago in JAMA Internal Medicine, and it addresses a problem we all face.
The SAVE-02 AI trial. 300 adults across 4 U.S. hospitals randomized to either a closed-loop autonomous oxygen system or standard clinician-managed oxygen. The system continuously monitors pulse oximetry and automatically adjusts supplemental oxygen flow to keep saturations between 90 and 96%.
So a machine does what the nurse or doctor would normally do manually. Walk in, check the sats, turn the dial, except the machine does it every few seconds instead of every few hours. Who funded this?
The U.S. Department of Defense. The senior investigators are Adit Ginde from Colorado and Matthew Semler from Vanderbilt. Names you may recognize from the classic saline versus balanced crystalloid trials. The population was acutely ill adults, respiratory illness, trauma, burns, post-operative patients, anyone on supplemental oxygen.
And the primary outcome was the proportion of time patients spent in the target saturation range. That's a process measure, not a clinical outcome. I want to know why they chose that.
Because oxygen harm works both ways. Too little and you get tissue hypoxia, end organ injury. Too much and you get oxidative stress, absorption, atelectasis, and in vulnerable patients, worse outcomes. The target range isn't arbitrary, it's the sweet spot.
So the logic is that more time in range should translate to better outcomes even if the trial wasn't powered to show mortality difference. Fair enough, but I'd note that we've been burned by process measures before. Tight glucose control in ICU looked great on paper, then nice sugar showed increased mortality. So I'm cautious about process endpoints.
That's a fair caution. The difference here is that oxygen is more directly mechanistic. Hypoxemia causes tissue injury within minutes. Hyperoxemia has dose-dependent harms. The causal chain from time in range to outcomes is shorter and more plausible than glucose. But you're right, this trial does not prove improved mortality, it proves better control. What did they actually find? The numbers are striking. Patients on the autonomous system spent 85% of their time in the target range compared to 63% with usual care. That's a 21 percentage point improvement. Time in hypoxemia, meaning saturations below 88, dropped from 3.6% to 2%, and time in hyperoxemia above 96 dropped from 29% to 9%.
Let me translate that. With usual care, patients were spending nearly a third of their time over-oxygenated. That's a lot of unnecessary oxygen exposure, and the autonomous system cut that by about 2/3. The hypoxemia reduction is smaller in absolute terms, but still meaningful.
There was no increase in serious adverse events. Patients on the autonomous system also used about 23% less oxygen overall, which has cost and supply implications, especially for rural hospitals where oxygen cylinders are a finite resource.
Here's my honest devil's advocate question. This is an unblinded trial. The clinicians knew which patients were on the autonomous system. Could they have paid less attention to those patients? Or conversely, could the Hawthorne effect have improved usual care in the control arm? Either way, the gap might be smaller in real-world deployment.
That's a valid concern. Unblinded device trials always carry that risk, but the objective was time in range, which is measured continuously by the device itself, not by subjective assessment. The Hawthorne effect would more likely narrow the gap, not widen it, so the true real-world benefit might be even larger.
And there's a practical reality check. This system, the O2matic PRO100, isn't widely available in Australian hospitals yet. It's a Danish device, CE marked but not standard equipment here. So this is a watch and prepare story, not a change practice tomorrow story.
Exactly. But it tells us something actionable regardless of the device. Our manual oxygen titration is leaving patients outside the target range for over a third of the time. If you run a ward or an ED, ask how often oxygen is actually being reassessed. The answer is probably not often enough.
Tell your wife about this next one. It's about antenatal corticosteroids in women with diabetes.
This is a population-based cohort from New South Wales, published in the August issue of the Australian and New Zealand Journal of Obstetrics and Gynecology. Ibanabo Ibabeli from the University of Sydney. Over 5,000 women who gave birth at 35 weeks or later between 2016 and 2021.
Wait. Antenatal corticosteroids for fetal lung maturation are standard when you're delivering preterm, before 34 weeks. But this is late preterm and term. Why would you give steroids at 35+ weeks?
That's the core question. The use of antenatal corticosteroids has been expanding into the late preterm window, 34 to 36 weeks, and even early term. The evidence for benefit at these gestations is genuinely thin, and in women with diabetes, there's a specific concern. Steroids spike maternal glucose, which can cause neonatal hypoglycemia.
So the theoretical benefit of better fetal lung maturity is pitted against the real risk of worse neonatal metabolic complications. That's a genuine clinical tension. What did they find?
The headline finding is that women with diabetes who received antenatal corticosteroids had no improvement in any maternal or neonatal outcome compared to women with diabetes who did not receive them. No difference, but when they compared diabetic women who got steroids to non-diabetic women who got steroids, the diabetic group had 61% higher risk of neonatal hypoglycemia and 18% higher risk of nursery or NICU admission.
So the steroids didn't help and may have caused harm, specifically in the diabetic subgroup. But I have to flag the elephant in the room. This is a cohort study, not a randomized trial. The women who got steroids were almost certainly different from those who didn't. Sicker patients, earlier gestations, multiple pregnancies, more cesareans.
Absolutely. The authors acknowledge this. Women who received corticosteroids had higher rates of hypertension, hospital-based antenatal care, multiple births, and cesarean section. Confounding by indication is the major limitation. The sickest women were the ones who got steroids.
Which means we can't say the steroids caused the hypoglycemia. It could be that the women who needed steroids were already at higher risk. But the absence of any benefit in the diabetic group is still concerning. If steroids aren't improving outcomes and may be adding risk, we need to question the expanding use.
The mechanism matters here. Betamethasone and dexamethasone both cause significant maternal hypoglycemia. In a diabetic woman, that's harder to control. The fetus responds with hyperinsulinemia. After birth, when the maternal glucose supply is cut, the fetal hyperinsulinemia persists, and you get neonatal hypoglycemia. This is well established.
So the biological plausibility for harm is strong, even if the observational design limits causal claims. What's the practical takeaway for your wife's obstetric practice?
Be cautious about giving antenatal corticosteroids to diabetic women at late preterm or early term gestations. The standard indication remains threatened preterm birth before 34 weeks, where the benefit is clear. Beyond that, in diabetic women particularly, weigh the uncertain benefit against the metabolic risk, and if you do give them, anticipate and prepare for neonatal hypoglycemia.
Story 3. Knee osteoarthritis. This one is pure general practice.
You know the patient, 55-year-old woman, knee pain for years, X-ray shows moderate osteoarthritis. She's tried paracetamol, topical NSAIDs, maybe physio. She wants something more. And someone, maybe a well-meaning colleague or a patient forum, has mentioned Diacerein.
Diacerein, the interleukin-1 beta blocker derived from rhubarb and aloe vera. It's been used in Europe and Asia for decades. The theory is sound. Interleukin-1 beta drives cartilage degradation and inflammation in osteoarthritis. Block it, reduce inflammation, reduce pain.
A DICKENS trial, published in JAMA Internal Medicine. Dawn Aiken and the team at the Menzies Institute in Tasmania, 262 adults across 4 Australian centres. This is the largest trial of Diacerein globally, and they did something smart. They selected patients who should benefit most.
They enriched the population for the inflammatory phenotype. Every participant had MRI-confirmed effusion synovitis. That's fluid and inflammation in the joint. If Diacerein works anywhere, it should work in patients with actual inflammation. This was the Optimist trial.
50 milligrams of Diacerein twice daily versus identical placebo for 24 weeks. The primary outcome was change in knee pain on a 0 to 100 visual analog scale, where a meaningful improvement is 15 points or more.
And?
It failed. Diacerein reduced pain by 19.9 points. Placebo reduced pain by 18.6 points. The difference was 1.3 points. The confidence interval was -9.8 to +7.3. It crossed 0. There was no signal of benefit whatsoever.
Both groups improved by about 19 points. That's a substantial placebo response, which is classic for osteoarthritis trials. But the drug added nothing on top, and this was in the exact population where it was supposed to work best. That's a clean negative.
Diacerein also caused more side effects. 42% had gastrointestinal symptoms versus 25% on placebo. Diarrhea specifically, 39% versus 22%. So patients were taking a drug that didn't work and giving them diarrhea.
What does this mean for practice? Diacerein isn't widely used in Australia, but it is available, and some patients buy it overseas or online. This trial says don't start it, and if a patient is already on it, this is good evidence to stop.
The broader context is sobering. Knee osteoarthritis remains one of the hardest problems in general practice. We have paracetamol, which is marginally effective, NSAIDs, which work but carry renal and cardiovascular risk, intra-articular steroids, which help briefly, weight loss and exercise, which remain the most effective interventions, and now we can cross interleukin-1 blockade off the list.
It's worth connecting this to the broader pattern. Interleukin-1 blockade has now failed in osteoarthritis, in gout prophylaxis, and in several other musculoskeletal conditions. The IL-1 hypothesis in joint disease keeps looking promising in animal models and keeps failing in humans. At some point, we accept that the target isn't as central as we thought. The inflammatory phenotype in osteoarthritis is real, but blocking IL-1 isn't the answer. Quick hits before we wrap.
First, a new study in obstetrics and gynecology looked at semaglutide exposure in pregnancy. 429 women with semaglutide exposure in early pregnancy matched against non-users. The semaglutide group had higher rates of excessive gestational weight gain, gestational diabetes, and cesarean delivery. But this is observational data, and the women on semaglutide had higher baseline BMI and metabolic risk. It does not prove semaglutide caused these outcomes. The RANSCO guidance remains contraception for all women of reproductive age on GLP-1 receptor agonists.
Second,
PBS September brand deletions. From September 1st, several brand name drugs are being removed from the PBS schedule. Amoxil capsules, Cardizem CD, Actose, and Polyvisc eye ointment. If you have patients on these specific brands, transition them to the remaining generic equivalents. The active ingredients remain available.
All right, recap.
1. Autonomous oxygen titration keeps patients in the target range far better than manual management. Watch for this technology, but meanwhile, reassess your own oxygen practices. 2. Antenatal corticosteroids in diabetic women at late preterm showed no benefit and higher neonatal hypoglycemia. Be cautious beyond the standard preterm indication. 3. Diacerein does not work for knee osteoarthritis even in patients with inflammation. Don't prescribe it.
3 solid stories. The oxygen tech is coming. The steroid data gives us pause, and the knee OA trial is a clean negative that simplifies our options.
See you tomorrow. Stay sharp.